Good morning, everyone. It's my pleasure this morning to introduce you to our next internal medicine grand rounds. And to do our introduction of the introduction, I'm going to turn it over to Dr. Mohammed Saad. He is our chief of the Pulmonary and Critical Care Division, as well as Sleep Medicine here at University of Louisville. And he has been a long time faculty member and worked his way up through the ranks here. He is actually been a leader in the area of pulmonary critical care for several decades, and we appreciate all that he's done. And he's going to introduce our introducer. We're very happy to have Dr. Flora here talking about interstitial lung disease. Dr. Saad?
Yeah, good morning. Thank you, Dr. Williams. Good morning, everyone. It's a pleasure to welcome you to the first pulmonary and critical care medicine grand round for this academic year, and we are clearly fortunate and privileged to have Dr. Flora joining us today for an important talk, and which is relevant to our ILD program. I'll have Dr. Gohar introduce our speaker, but I want to thank Dr. Flora for taking time to join us this morning. Thank you.
All right, good morning, everybody, and thank you for being here. Today we have Dr. Arjan Flora as our guest speaker. Dr. Flora is the Director of Interventional Pulmonology with the University of Tennessee, Memphis, particularly at the VA hospital in Memphis. Dr. Flora got his medical education and training in Toledo, Ohio, followed by his Pulmonary and Critical Care Fellowship over there. He then did a dedicated Interventional Pulmonary Fellowship at University of Cincinnati in Ohio. Dr. Flora has held faculty positions at Albert Einstein in Philadelphia and University of Cincinnati. He also has military service with the Tennessee State Guard and the Ohio State Guard. Dr. Flora, in his very young career, has several peer-reviewed publications to his credit, as well as presentations at national meetings. And we are very fortunate to have him today talk about a topic which is somewhat complex, at least from my standpoint, and he's going to discuss interstitial lung disease and the role of interventional pulmonology in the management of interstitial lung disease. So thank you, Dr. Flora, and I will hand it over to you.
Thank you so much for the Department of Internal Medicine for having me. Let me share my screen here. Are you able to see my slides?
Yes, looks perfect.
Okay. As Dr. Gohar had mentioned, this is a very complex disease process with interstitial lung disease. There are hundreds of different causes for interstitial lung disease. It's not just one disease entity, but many different processes that occur, as well as different parenchymal processes that do occur. So it does get very confusing, and that's where the interventional pulmonologist can be of assistance in the diagnosis of patients. I have no financial relationships or conflicts of interest to disclose. So the objectives would be knowing what interstitial lung disease is. It'll be a very brief overview and the current diagnostic approaches. Then we'll be learning about what is the role of the interventional pulmonologist in the diagnosis of ILD, and then exploring future procedures in the diagnosis of ILD. So just a brief overview. I know these are some busy slides. That's more for review for later if anybody wants the slides, but I will not be reading off of them. So that way you won't be so bored in the morning. So diffuse parenchymal lung diseases is basically collectively referred to as interstitial lung disease. As you can see in this graphic over here, there's many different branches of this overlying umbrella terminology of interstitial lung disease. You can break down interstitial lung disease into those with known causes and then those that are idiopathic. Of particular interest of mine, especially being in the VA system, are military occupational exposures and environmental exposures that could lead to the development of interstitial lung disease. But then you also have drug toxicities and connective tissue diseases that can result in interstitial lung disease. Then you have the complexity of those idiopathic ones, which is kind of where the role of an interventional pulmonologist or even a surgeon would come in. But why is this important? It's because the treatment choices and the prognoses vary depending on what that interstitial lung disease is. Two particular examples that I mentioned here on this slide is that with scleroderma with severe ILD has a 9-year survival of 30%, while idiopathic pulmonary fibrosis has a median survival of 2.5 to 3.5 years. So getting the diagnosis is important because only several years ago did we have any medications aside from oxygen, steroids, and immunosuppressive agents in which to slow the progress of pulmonary fibrosis. In particular, looking at this slide at this Kaplan-Meier curve, you can see that antifibrotics have the ability to slow down the disease progression. And as I had previously mentioned, the median survival is very low for these patients. So getting the diagnosis early is very important to our patient population. The number one thing in the evaluation is a complete history. I'm of the mindset as an internist first, is that 90% of your diagnosis is going to come from a good history and physical examination. That gives you a good pre-test probability that leads to then your further imaging, laboratory testing, for example. So age and gender, you're going to find that certain patient populations in their 20s and 40s are going to have things like Langerhans histiocytosis, sarcoidosis, connective tissue diseases, while going into age 50 and above, you're going to see more along the lines of pneumoconioses from occupational exposures, as well as idiopathic pulmonary fibrosis. Then the onset of symptoms, you'll have some patients who will have a chronic or indolent presentation versus something that's more acute or subacute, like in hypersensitivity pneumonitis. Past medical history, again, there's a plethora of disease processes that can occur because of drug toxicities. Smoking history, it plays a big role, especially when you're looking at respiratory bronchiolitis, ILD, or discriminative interstitial pneumonia. Family history, I've actually been seeing quite a few of the familial pulmonary fibrosis patients lately, and that's because it's starting to become more recognized. And then again, as I had mentioned, occupational environmental exposures. When I had done some of my medical training in New York City, I was seeing a lot of patients that were involved with the World Trade Center collapse, and a lot of the inhalation exposures that they had, basically from the pulverizing of the buildings and the dust that was inhaled, they started having sarcoid-like reactions. I'm also seeing that a lot in the military population as well here at the VA. So aside from a good history and physical, there are some biomarkers that are available, especially when you're looking at connective tissue disease related ILDs. So an ANA panel, as well as the breakdown of within that panel. ANCA, for example, if you're looking for GPA or eGPA, and then a hypersensitivity panel if you want to see if you can pinpoint what the actual exposure was for a hypersensitivity pneumonitis. And then imaging is also varied as well. Sometimes some patterns on imaging can be pathognomonic to the underlying disease process that's occurring. And it can also help guide you on what the therapy that you need and how severe things can go. A particular note is the acute interstitial pneumonia. The survival rates for that are very low, and you'll tend to see a lot of these patients in the ICU. So in particular, something that is more concerning of all of these processes is idiopathic pulmonary fibrosis. Just this year, the American Thoracic Society had come out with IPF guidelines, and they identified 4 radiological patterns. UIP, or usual interstitial pneumonia, tends to be pathognomonic for IPF That is to say, if you have not been able to identify rheumatoid arthritis or a chronic hypersensitivity pneumonitis. But having, looking here on the left at the UIP pattern of subpleural or basal predominance, honeycombing, let me point this out here. So honeycombing, which you can see along here, as the name implies, it does look like a honeycomb. And you can have peripheral traction bronchiectasis, so when the fibrosis pulls open the airways. And then it would have a reticular pattern, so ret from the Latin for net, so it'll be a net-like pattern that you will see. That's the thickening of the septations of the lobules. When you do see this pattern and you are thinking of idiopathic pulmonary fibrosis, you have a higher diagnostic confidence. You do not need to have a biopsy when you are thinking IPF and you see this UIP pattern. But then when you start getting into these probable UIP pattern or indeterminate UIP, or even a potential alternative diagnosis, that's when you're going to have to use different modalities other than imaging, other than your laboratory testing, other than your clinical evaluation to really try to pinpoint what is the underlying disease process that's occurring. So in this algorithm here, you have a patient that's suspected of having IPF. You go through potential causes or associated conditions. Now, if you do have that, you can get confirmation of that specific diagnosis, whether it be getting a high resolution CT, getting additional biomarkers, being able to identify the associated condition based off of exposures, and you can come up with an alternative diagnosis. However, if you don't have that, and again, being idiopathic, you get this high resolution CT. If you do see that UIP pattern, you could be close to definitive to saying that this is IPF. However, that does include a multidisciplinary discussion, and that is the key for interstitial lung disease, is having your pulmonologist, having your radiologist, having your pathologist if you do end up getting tissue, and multiple specialties discussing coming up with a consensus of a diagnosis. However, for these indeterminate UIP patterns or potential for alternative diagnosis, this is now when you start to get into the more procedural side of things, or even surgical. And then when you have that, then you can discuss again to see is IPF or an alternative diagnosis present. So in those particular cases of where a workup is needed with a procedure, standard, in terms of standard workups, the simplest thing is a bronchoalveolar lavage. As you can see in this diagram here, the bronchoscope goes into the airway. You wedge into the area of interest based off of your imaging. The normal cell count in differential should be predominantly alveolar macrophages with about 10 to 15% lymphocytes and a smaller number of neutrophils, eosinophils, and some squamous epithelial cells. However, when this breakdown alters and you have a predominant neutrophilic cellular pattern, you do have these potential lists of disease processes that can occur, versus if you have a lymphocytic pattern, you still have a long list of potential diagnoses. And then for eosinophil predominance, you have a breakdown. So BAL itself is not necessarily diagnostic. It can only give you a classification of non-specific, consistent with, or suggestive of. And so there are some limitations to a basic BAL. The next thing would be a transbronchial lung biopsy. However, the diagnostic yield for a transbronchial forceps biopsy, that is, and just quickly, transbronchial is a misnomer. You are not going through the bronchus, rather you're traveling down the airways until you reach the parenchyma. And so just this little diagram to show. But for idiopathic pulmonary fibrosis, a forceps biopsy has a very low diagnostic yield, about 20 to 30%. But then when you're looking at other non-fibrotic ILDs, it could be as high as 80 to 90%. So forceps biopsy could be the procedure of choice for things like sarcoidosis, hypersensitivity, pneumonitis, eosinophilic pneumonia, and cryptogenic organizing pneumonia. However, when we're going into something like idiopathic pulmonary fibrosis, there are limitations to it. The more definitive gold standard would then be the surgical lung biopsy. And the rationale for that is tissue is the issue. The more tissue you get, the more likely you are to get the diagnosis. Now, looking at this meta-analysis, the diagnostic yield for surgical lung biopsy is 95%, with IPF being the most frequent diagnosis. However, when you look at the mortality rate, 3.6% may not seem like a lot, but you obviously don't want your patients dying simply trying to come up with a diagnosis. And there's a significant heterogeneity in this number, and that's only because of the studies that were involved. They had different exclusion criteria. Did they include patients that had an immunocompromised state? Were these patients on mechanical ventilation? Did they exclude patients who did have severe respiratory function? And one thing that I did not mention on this slide is that patients who do have surgical lung biopsies can have an exacerbation of their idiopathic pulmonary fibrosis from the surgery itself. So there are some limitations from this gold standard. Looking at this statement from a consensus statement from ATS, the European Respiratory Society, and many other organizations for this clinical practice guidelines for diagnosis of IPF, they broke down the biopsy method, the adequate samples if they exist, the histological diagnosis coming from it, and the complication rate. So again, looking at transbronchial lung biopsies from the forceps, while you may get 78% adequate samples, the chance of you getting a diagnosis is fairly low, 36%, while the pneumothorax rate is 10.2%, and PAL is persistent air leak. So not just having the pneumothorax, but then they end up getting a chest tube, and now they have a persistent leak for 4 to 7 days after. And so that does prolong hospital stay times, that does increase the risk of morbidity and even the chances of mortality. I will be getting into this, so I won't touch upon this. But surgical lung biopsy, 100% chance of getting an adequate sample, but you still only get about an 89% histological diagnosis. And as we had mentioned, the peri-procedural mortality and IPF exacerbations are the main complications from it. But this middle option, transbronchial lung cryobiopsy, when you're comparing the two, you get, it's fairly close to the surgical lung biopsy, which again is the gold standard. Again, your histological diagnosis is fairly close, but your complications are a little bit closer to that of the forceps biopsy. And that's where the role of the interventional pulmonologist comes in. So what is transbronchial cryobiopsy? I just wanted to give this is not an endorsement to this company, but it's the only one that's available in the United States. But as you can see here on the right, we have this probe in which, utilizing CO2 gas, you can make an ice ball at the tip of it. This is just showing the freezing times of 3 seconds versus 10 seconds of these different probes. And again, tissue is the issue, so it's the size of the biopsies that you're trying to get. And these are just showing just the proportion of bronchial wall tissue that's obtained versus alveolar tissue with these different catheter sizes, or rather probe sizes. So where do you necessarily target in order to get your diagnoses, as well as your diagnosis for your tissue sample? And then what are the complications? So your target area is going to be around here. I'm not certain if you can see the airway in the back here behind this target, but the key is to get alveolar tissue, to get the parenchyma itself for this parenchymal lung disease. Now, the risk, if you're going all the way to the edge to the pleura, you have a very high risk for pneumothorax. But as we had seen in the imaging for UIP, we want to get that subpleural process. We want to get that tissue in order to make that diagnosis for our patient. And so, do you risk getting that pneumothorax in order to get that answer? And so you want to try to get as subpleural as possible without that risk of pneumothorax. And so this target area will have a lower risk of pneumothorax and a lower risk of bleeding. However, if you don't get far enough into the periphery, you have medium-sized vessels of the pulmonary arterial branching. You don't have complete cartilage from the airways that are protecting those vessels, and therefore you have a high rate of bleeding. And some of that bleeding can be significant enough to cause massive hemoptysis. And as you can see in this fluoroscopic imaging, you can see the bronchoscope here with the probe coming out, trying to get into that target area. You're not up against the pleura, but you're at that target area here. Part of the issue too is this curvature. When you're trying to pass the probe along, because of this bend, that probe can actually be touching onto the airway wall itself and not actually up into the parenchyma itself. So that also increases the risk for complications of this procedure. Just briefly, there are different ways to do this procedure. The most common way that's utilized is using rigid bronchoscopy and having a balloon catheter in place. And so you'll have a balloon catheter alongside at that airway that you're targeting. Once you get the ice ball made, you actually have to, for lack of better terms, yank the tissue out. You cannot pull it through the working channel of the scope because it is a bigger piece than using a forceps. And so you have to remove the tissue, the probe, and the bronchoscope en bloc all together. And that leaves the patient very vulnerable for bleeding. And so you would have a balloon catheter sitting in the airway to inflate in order to tamponade the bleeding. Another method, the one that I use, is a two-scope technique. So once you remove this en bloc, you go in immediately with the second scope and you wedge into the airway, into the exact airway where you got the biopsy and tamponade, so that you prevent blood flowing to the rest of the bronchial tree, which could decrease the dead space or increase dead space ventilation and cause some complications intraprocedurally. So in 2009 is when transbronchial cryobiopsy was proposed as a new tool. This particular study was just a feasibility study to see does transbronchial or comparing transbronchial lung biopsy with forceps to transbronchial cryobiopsy. The key difference again is tissue size. When you're looking at a forceps biopsy, your specimen size is very small. You can see that there's very scant, tiny little pieces of tissue that's available. And then when you're looking under the slide, you can see again, very scant tissue. But the issue too is that you have crush artifact, that forceps actually crush the tissue. And so this makes it very difficult to make a diagnosis versus using the cryo probe. And you can see this ice ball over here, where you're getting much larger pieces and you have preservation of the tissue in order for the pathologist to make a better call. And you can see that the specimen size is considerably larger. Just to focus on the diagnoses as well. So again, no real difference when you're looking at DIP, lymphangioliomyomatosis or LAM, hypersensitivity pneumonitis, sarcoidosis between using history, lung function, CT scanning, forceps biopsies, and cryobiopsy. Not much of a difference. But the major difference comes in again with IPF, UIP, and then non-specific interstitial pneumonia. And so years later, after much smaller studies, case series, retrospective studies, there was finally a call for standardization of the procedure. Again, there are two different methods. There's a lot of variability in the literature, and there was a call for standardization of the procedure. And so what are the indications for transbronchial cryobiopsy? It's again, diffuse parenchymal lung disease in which tissue diagnosis is indicated. I starred this because again, a good history and physical, good understanding of the imaging, getting ancillary laboratory testing in order to make a call on what the disease process, and then having a multidisciplinary discussion should be able to get a diagnosis for your patient. So when tissue, again, is the issue, that's when cryobiopsy would come into play. Now, in terms of contraindications, as I had mentioned, bleeding risk is a major concern. And so if there's a bleeding diathesis or active anticoagulation therapy or thrombocytopenia, that would be a absolute contraindication. The same issue would happen as well as if you had bleeding, loss of the airway, hemodynamic instability would make things very difficult for this procedure. In terms of relative contraindications, pulmonary hypertension is listed. I had done many cases with severe pulmonary hypertension without any complications. However, again, that depends on the training of the individual doing the procedure and being able to handle potential complications peri-procedurally. Having severe restrictive lung disease, again, these are going to be issues while you have these patients under general anesthesia. And if you do have increased bleeding into the airway, having a decreased diffusing capacity would make complications occur in terms of oxygenation of the patient. And so now looking at those complications, this study came out from Vanderbilt looking at the 30 and 90-day mortality for transbronchial cryobiopsy. In terms of the 30-day mortality, it was a case retrospective review of 197 patients. They had a 2% 30-day mortality and a 2.54% 90-day mortality. Looking at all-cause mortality for inpatient procedures, so you would think that these patients are already very sick and you're wanting a diagnosis so you can take care of them. Their 30-day mortality was as high as 25%, while outpatient procedures, when patients were more stable, was a low 1.1%. So after the reporting of this, Vanderbilt stopped doing transbronchial cryobiopsies on their inpatients. Now, for myself, when I was at the University of Cincinnati, we were doing inpatient cases. I had actually diagnosed a couple of acute interstitial pneumonias on very sick patients in the ICU. There was a paper that came out from both Albert Einstein, where I was, as well as University of Cincinnati, that was looking at their complication rate. I did not include that slide here, but the mortality was very high as well. So the value of doing transbronchial cryobiopsy is not really there. You may get a diagnosis, but the patient may not survive to make that diagnosis worthwhile. Looking back at retrospective review and cost analysis on these patients, so the diagnostic yield for transbronchial biopsy with the forceps in 11 studies was 64%. Looking at the diagnostic yield for transbronchial cryobiopsy as high as 84%, while a surgical biopsy in 24 studies was 91%. Looking at the complication rate, again, this is just kind of driving home the point. Your two major risks are going to be pneumothorax and moderate bleeding. My own personal pneumothorax rate is about, it went up to about 6%, but I've been kind of sticking around 4% with my cases. But when looking at the literature, it's about 6 to 10%, averaging about 8%. And then moderate bleeding risk is 21%. So again, it's being able to handle these peri-procedural complications is going to be the key issue, the key issue here. But looking at the cost analysis, if you're going to send a patient for a surgery, you're going to be spending a lot more money, a lot more resources, anesthesia time, OR time, post-hospitalization. So while a pneumothorax risk for a transbronchial cryobiopsy is 10%, it's 100% with a surgery. The patient will have a chest tube and they will be admitted for 5 to 7 days. And so there are potential savings from doing a transbronchial cryobiopsy over doing a surgical lung biopsy for select patients. And then again, just looking at a systematic review and meta-analysis, for cryobiopsy. Histological diagnostic yield 83%, adding in the multidisciplinary component of it, 79%, or rather just multidisciplinary discussion alone is 79%. But again, pneumothorax rate is 12%, moderate bleeding rate is 39%. And so they made a statement in this paper that the diagnostic accuracy of cryobiopsy can't be determined when comparing these meta-analyses. And so this CHILL study came out of where they prospectively looked at where they did a sequential transbronchial forceps biopsy, then they did a cryobiopsy, and then they did a surgical lung biopsy. Now that's a very involved study, so they were only able to enroll 16 patients in 4 years. When they looked at the raw agreement between cryobiopsy and surgical lung biopsy for multidisciplinary diagnosis, there was an agreement of 68.75%. And when you look at the kappa value, it was 0.6. I added a little table on the bottom to show what that means in terms of the strength of agreement. So it's moderate to good in terms of agreement. But when you're looking at the raw agreement between forceps biopsy and cryobiopsy, that kappa is 0.21. And when you're looking at forceps biopsy and surgical lung biopsy, it's 0.08. So using forceps is probably not the way to go if you're going to be evaluating a patient utilizing a bronchoscopic procedure. So there was a discordance between cryobiopsy and surgical lung biopsy. Why is it that, yes, you're getting bigger tissue pieces, but why isn't it the same as a surgical lung biopsy? And the main issue is the pathologic features. Again, it's that subpleural architecture is missing. Surgical lung biopsy, you are able to get that subpleural tissue. Cryobiopsy, because of the fear for pneumothorax, is less likely to get that. And so when you're looking, if all 4 features that you would expect from UIP were present, you'd get that from a surgical lung biopsy, but it's much harder to get from the cryobiopsy because of fear of pneumothorax. And so again, just focusing on that target area, the avoidance of pneumothorax makes the diagnostic yield a little bit lower because the probe is being pulled back. And so in 2022, this year, or just several months ago, there was an update for IPF and progressive pulmonary fibrosis in adults from the American Thoracic Society. And so they actually made a statement about transbronchial lung cryobiopsy. They do suggest that it is an acceptable alternative to surgical lung biopsy when you are working up an interstitial lung disease. But the key issue here is that this should only be done at a medical center with experience performing the procedure. And then what's also very important is actually the pathologist to interpret that tissue. Because again, if you're missing that subpleural predominance, you need to have the pathologist be able to confidently make that diagnosis. And there's also that risk for sampling error because, again, pulling back that probe and not getting as subpleural as you potentially can. And a lot of that has to do with a lot of the research that's out there. Again, there's no standardization for the procedure yet, and the literature varies in terms of the outcomes. And so what can you do if you want to help make a more clearer diagnosis? Over the past couple of years, there's been a genomic classifier that came out using RNA. There was 3 studies that were involved in order to make this happen: BRAVE 1, BRAVE 2, BRAVE 3. And so they did whole transcriptome RNA sequencing in BRAVE 1 using surgical lung biopsies. In BRAVE 2, they did it with forceps biopsies. And then in BRAVE 3, they added forceps biopsies and cryobiopsy in order to help make this classifier. Now, again, I'm not endorsing this. It's just that this is the only one that's really out there right now. But the classifier does not confer a clinical diagnosis, and it should be interpreted in the context of other clinical factors. So again, very good history and physical, high resolution CT, ancillary testing, and then if you get tissue, because you're already doing a bronchoscopy, if you're going to get this classifier, you have tissue. Now it's just yet another modality that you can add for that multidisciplinary discussion. And so in that statement from earlier this year, there are no recommendations for or against it. I did add the rationale. The committee was pretty much split between using the classifier and not. For those who did not recommend it, they have a long list of why they would not want to recommend it. But I won't go into that debate for this lecture. So what is the future? You know, there's complications with getting a surgical lung biopsy. There's complications with getting a cryobiopsy. The issue of a low diagnostic yield with forceps biopsy, not coming up with a diagnosis and just kind of pushing you one way or the other with the BAL. And then the limitations itself when you have an indeterminate pattern on imaging. Well, there's new technology that's coming out. It's still fairly nascent, but it's starting to make its way into the clinical side of things. In my discussions with various VAs that do post-deployment airborne hazards and burn pit exposures for interstitial lung diseases, this is something that we've been starting to talk about as a potential. So optical coherence tomography. So again, this is something that is a procedure. It's a bronchoscopy, but rather than a biopsy, you place a probe that uses near infrared light to generate high resolution imaging. It's already being used in interventional cardiology and in vascular surgery. So down here, this is imaging from vascular optical coherence tomography, looking at the vasculature and the surrounding tissue. But this one is endobronchial, bronchoscopic. Now, I don't know how many people know about radial EBUS or radial endobronchial ultrasound, where you get a 360-degree view by placing a very thin ultrasound probe into the airway. But one of the issues with that is using ultrasound, and you have to make contact in order to see the tissue. With OCT, because you're using near infrared light, you actually don't have to necessarily make contact, and yet you can get this very detailed microscopic views of the tissue for a depth of about 2 to 3 millimeters outside of the airway, and you get a resolution of 10 to 15 micrometers. And so this is more conceptual. However, now there are studies coming out of using it for the diagnosis of UIP. So this was a very nice study. This was actually presented in the year in review for the American Thoracic Society in May. And so this is really starting to become very exciting for pulmonologists in general. I know this is a very busy slide, but again, this is just if anybody wanted to review later. But at this point, we're able to actually describe, based off of the OCT imagings, what the equivalent would be in the microscopic features for UIP, emphysema, NSIP, and airway-centered fibrosis, and in great detail. So in this particular study of 27 patients, where they looked at 12 patients with UIP and 15 with non-UIP ILD, the sensitivity and specificity of optical coherence tomography was 100% and 100% respectively for both UIP and clinical IPF. And they did get biopsies via surgical lung biopsy after using OCT, and they found a very high agreement of 0.87. So this is something very exciting, where it's less invasive for the patient. They may not even need any surgical or procedural biopsies in order to get a diagnosis. and it's still fairly nascent. This is something else. That's their confocal laser endomicroscopy. This is actually being used in lung cancer a lot, and now it's being utilized for interstitial lung diseases as well. And now you can actually see down to a depth of 70 micrometers with a resolution of 3.5 micrometers. So this is also very amazing stuff when at how much detail you can see the architecture. And really for very early ILD, you can start to see the very early parenchymal changes using these technologies for an earlier diagnosis. So you may not even see a lot of changes on CT imaging when you get it, but you can start to make these early diagnoses. And it can be done different ways. There's actually you can use a needle as well, so you can stick it into a lymph node if you want to see for metastatic disease, or you can put it through the airway. And then I was not able to find any clinical papers on this yet. Nothing that's being used clinically, at least in terms of ILD, more in terms of lung cancer. But this study actually was done to actually clarify what are these imaging showing. So this is just very cool. When you're looking at the normal alveolar tissue, you can see the alveoli and the septations between them. When you're looking at organizing pneumonia, you can actually see the focal consolidations in here. And NSIP, you can see the increased density of the parenchyma. And you can see in chronic HP, you can see the consolidations, the distortion of the architecture, and the increase in the density. In IPF, you can also see just all the significant distortion and destruction of the parenchyma. And then even for amiodarone lung disease, all this stuff right over here is actually macrophages. And you can see that in extreme detail. So this is all very exciting for the future. And then this one was actually just using the laser endomicroscopy as a guidance tool for cryobiopsy. So in this particular study, you know, when you're passing the cryo probe through the airway using fluoroscopy, you may not be able to actually target where you want the probe to go in order to ensure that you have tissue. But so they used the confocal laser endomicroscopy as a guidance tool in order to target where they would get their cryobiopsies from. And so when you're comparing, I mean, it's just absolutely amazing how you can see this in extreme detail and it matches the pathology almost exactly. And then this is just comparing the images of both OCT and CLE and what they would look like in comparison to each other. And then this just here on the left just kind of goes through the details of what you're seeing on imaging and pathology. So the take-home points, you know, diffuse parenchymal lung diseases or ILD, especially IPF, may portend a progressive morbidity and mortality in patients. Thus, it's very important to get an early diagnosis so that you can start treatment early. Transbronchial cryobiopsy is a safe alternative with moderate agreement with surgical lung biopsy. The point that I would make here is that those patients who cannot tolerate a surgery, this is probably a good alternative for those patients. And then if you're already going to have a patient undergo a procedure, better not to waste time with the forceps biopsies, just because you'll get the fairly similar risk for pneumothorax, maybe not the risk with bleeding, but it is something that can support a multidisciplinary discussion if you need tissue. And then if you're still uncertain while you're doing the procedure, you can add the genomic classification. And then finally, there's just an exciting new future with non-surgical, less invasive bronchoscopic imaging modalities for the early diagnosis of ILD, and it may obviate the need for biopsy. Thank you very much for having me. I really do appreciate it. My sister did graduate from the family medicine program at UofL, so I find this a very exciting to be able to speak to the IM department.
Outstanding, Dr. Flora. Great presentation. Let's see. We'll hand off. We'll go ahead and Dr. Williams, I'll let you start us off with questions.
Well, thank you. No, I'll turn it over to Dr. Saad. I think most of us are amazed by the difficulty and what seems to be the increasing prevalence of ILD and the occupational exposures. And, if I had to ask a question, it would probably be a little bit more logistic, showing the slide that you showed with burn pit. And just wondering, don't we have connections with the VA and pulmonary expertise to avoid that from happening and becoming a big deal on Grey's Anatomy, and those of us who have family members who were in the military who were exposed, and we all feel like this is something that should have been known and shouldn't have ever occurred. But I know that's more of a practical. It's not so much political. It's more practical. How do we maintain communication between our military medicine and military operations to stop things like this from happening in the future?
I don't want to get political because I had my discussions with active duty pulmonologists in the past, who they kind of change their tune when they retire, because there's one thing from the Department of Defense and what they say versus what VHA, the Veterans Health Administration, says after, in terms of airborne hazards and burn pit exposures. But since the signing of the PACT Act a couple of months ago, there's now more funding for not only research but also for treatment of these veterans. And now it's also automatic that if you were in Operation Iraqi Freedom, Enduring Freedom, Operation New Dawn, you automatically get VA coverage for 5 years. And so the main thing now is identifying those patients. Because just the same way with Agent Orange, there are many veterans who say, I was exposed in Vietnam, but in order to actually get that service connection is very tough, because you have to be able to say, I was at this particular point, location, this many clicks outside of Saigon, and this particular date with this particular unit, and then they have to look back to see, what did we actually use Agent Orange there? I think it's a little bit easier with the burn pits and with the recognition of airborne hazards while active duty. But again, they're putting the onus on the veterans to actually sign up into the registry. I tried to register a couple of veterans myself, and I was told actually from Washington, D.C. that I'm not allowed to register the veterans into the burn pit registry. They have to do it themselves. So really getting the word out there and getting them the link to do that online, and providing those resources for the veterans will help that out.
So there isn't widespread screening, doing pulmonary function tests or anything? We just wait for people to become symptomatic?
So that's a very interesting thing. So what we're identifying in terms of pulmonary function testing for burn pit exposure, the first finding is an isolated decline in diffusion capacity. Mm-hmm. And you're finding that in 21-year-olds, 22-year-olds, really young individuals. And sometimes that's missed because an isolated decline in DLCO, if somebody is not trained to look for those things, they'll say, oh, it's a sign of pulmonary hypertension. But why would a healthy 22-year-old have pulmonary hypertension if it's, if they have no family history of it? They're never smokers. They don't have any major underlying lung disease. The only thing was that they were at forward operating base Sharhana, exposed to the 5 burn pits there. That's the only thing that really links them. So being able to identify those patients is quite difficult right now, because even though there's a lot of talk about it, there isn't a good program yet. I would say for Louisville and the Louisville VA, the closest hub is the Nashville VA, where the post-deployment post-deployment cardiopulmonary evaluation network. There's only 6 hubs in the country, but Nashville would be the hub for Louisville. And then in terms of having detailed studies of the cardiopulmonary components and getting biopsies, that would be Washington, D.C., the Risk Center, which is War-Related Injuries and Illness Study Center. And that's based out of Washington, D.C. is what serves Louisville.
I see. Appreciate it. So Dr. Saad, Dr. Gower?
Yeah, thank you, Dr. Flora. This is great. I think the question we have is, do you think the cryo will be replacing the open biopsy, or there is still a role of open biopsy in the ILD?
I think open biopsy is still, there's still a role for it, but then actually getting, especially if it's a late presentation and the patient is already now so severe in their dyspnea or their PFTs are poor where they may not tolerate the surgery. I think that's where cryobiopsy really comes into play. But if you're finding somebody who is presenting early on, it really comes down again to, is there a standard way to get good pathology, knowing that there is risk for a pneumothorax? It's almost is the reward of getting the diagnosis worth that risk? Again, my pneumothorax rate is not as high as that of the literature. And I'm able to get at least 5 to 6 cryobiopsies, one from each segment, using my 2-scope technique. And so if there is diffuse disease or if there's patchy disease, I'm able to target those particular segments. And I'm able to make some good diagnoses with low complication rates. And I've not had any patient have any issues with massive hemoptysis, except for one. Actually, it was a veteran who lied that he stopped his Lopinox, and then he was already, when we noticed the bleeding, we looked at his belly, and you can actually see all the bruises that he was still taking his Lopinox. So aside from that issue, I've not had any major bleeding risks as well. I don't know if Dr. Gohar agrees with me or not.
Dr. Gohar? I think you might be on mute. Yep.
Yes, I think our pneumothorax rates have been lower than what's been reported. Now, I will thank you very much for the talk, first of all. And I'm glad that you mentioned a very important point, which is number one, the multidisciplinary nature of management of complex lung disease. And the second point is the value of the pathologist. The pathologist who's looking at our specimen has to be comfortable diagnosing a diffuse parenchymal disease on a relatively small tissue sample. And the third point, which I think translates into other areas of lung disease, including perhaps lung cancer, is that sometimes it's not the size of the tissue, it's the better preservation of the tissue architecture. And so I'm very glad that you mentioned it. I guess as an interventional pulmonologist, I have a question for you. With all these new tools and techniques coming up, what do you think are going to be the challenges for practicing interventional pulmonologists and training pulmonologists to acquire these skills to the point where appropriate utilization and standardization is possible? Because once you are out of training, these technologies become difficult to train on. So what do you think are going to be the challenges for interventional pulmonologists in using these techniques?
I think in terms of challenges, and then also those who get out of training, in terms of these optical coherence tomography, that is just simply passing a probe, just like you would pass a forceps biopsy, but you're not getting a biopsy in order to get those images. That, I think, is going to be a game changer in terms of training, because you really just have to ensure that you're just able to pass the probe and stay still and get those images at that point without getting a biopsy. And that you don't need to be an interventional pulmonologist for. And so I think that would be the main challenge for an interventional pulmonologist, is actually losing the caseload, because you aren't doing the cryobiopsies as a result. But again, that's going to be many years before any sort of guidelines or practice changes occur using that technology. But in terms of cryobiopsy, as it stands, if you don't have the cases under your belt during the training, you're pretty much playing a dangerous game outside of training, because you don't, as with any trainee, once you're on your own, you're on your own. There's nobody to back you up, really. And so if you don't get that training during your fellowship, and then you start trying to mess around in the airway without really getting that feedback from somebody who knows what they're doing, you can cause a lot of problems for your patients.
All right, Dr. Flora, we have a question from our chat area, and it's from Dr. Robert Emmons. He's one of our hematology and bone marrow transplant experts. And he would like to know, he says, chronic graft versus host disease is a fibrosing lung disease, which is often difficult to diagnose with standard biopsies. Are you aware of either cryo or laser technologies helping with that pathology?
Oh, that's a perfect question. I did leave the University of Cincinnati a couple of years ago, but that was one of the things that we were talking with our transplant team, was the utilization of cryobiopsy for those particular patients. I haven't followed up, so I don't know, but I think that just before I left, and that was like during the pandemic is when I left. So the number of cases were dropping down. We were getting a lot of our bone marrow transplant patients coming in as referrals to get cryobiopsies done. In terms of studies on that, I am not aware off the top of my head. I'm sure if I did a search, I would find something. And then in terms of the laser technology, again, it's so very new. There's just not a lot of literature that's out right now. But yeah, definitely at Cincinnati, the bone marrow transplant team was sending patients for us to do cryobiopsy as opposed to forceps biopsies.
I think you want to know, just real kind of quick, who at Cincinnati is could he contact about for information about that?
For the cryobiopsies?
Yeah, I believe so. Yes.
So the director of IP over there is actually, I can just.
Yeah, if you tell you what, if you can email it to me, and I'll forward it to Dr. Emmons.
I just sent the email address right now. Dr. Aragaki, he's the director of IP. Actually, I did have a little thank you on my first slide because he helped me out in putting this presentation together as well.
Yeah. Okay. Perfect. All right. We still got a couple of minutes. If anybody, you can unmute and ask, or if you want to type something in the chat area, we do still have a couple of minutes. If anybody has any more questions or any comments.
Okay. Well, we can fast forward to the cardinal minute.
Yeah, and if you can just give me one moment, we have have a special presentation, a little something for Dr. Flora. As been a tradition for the UofL, for our department, for our guest speakers for grand rounds, whether in person or virtual, as it's been for the last couple of years. We have a little gift for you that is very synonymous with the city of Louisville. So in just a little bit, you will be getting your very own personalized Louisville Slugger bat.
Oh, I really do appreciate that. I've been eyeing that whenever I go to Louisville. So
yeah, as you mentioned, I know you said you had some interaction with with Jesse Roman a little bit, and yeah, he's actually the one that kind of started this tradition. So, but yeah, so I think I've got your home address in your CV, or if you want to email, I think, yeah, if you had a preferred address you'd like it shipped to, we'll get it to you. So.
I'm so honored. Thank you.
No problem. So, well, thank you again. Thank you, Dr. Saad and Dr. Gauhar for facilitating and inviting such a wonderful speaker and a great presentation. And We'll be back next week, same time. It'll be the George Pedigo lecture, and it'll be Nanette. Is it Winger or Wenger, Dr. Williams?
It's actually Winger.
Winger, okay, from Emory, and we're really looking forward to that. And I know as a friend of Dr. Williams, and I think it's going to be a great presentation. So thank you everybody for joining. Dr. Sauter, Dr. Gauhart, do you have anything you'd like to wrap up with, or?
Oh, thank you, Dr. Flora. This was great, and it was a pleasure to host you today, and great presentation, and looking forward maybe to see you in the future for a visit here. But thank you very much.
Thank you. All right. So I'm going to stop. All right. And thank you again.